Welcome everyone. My name is Rob Latika. I'm an online community manager with the European Organization for Rare Diseases, eurordis, and we're here today to do a PMP webinar along with the patient group Pseudomyxoma Survivor. If you have any questions, you can type them in the chat box and we'll try to get to those at the end. I'll make an effort to collect those questions and see what gets addressed during the presentations today and what also maybe we can try to cover at the end. This webinar is part of a PMP community that we have on Rare Connect. There's the community homepage. The community was founded about 2 years ago in April 2014, has just over 100 members from the different countries around the world that you see there. What's unique about the PMP community on Rare Connect is it's in 8 languages with human translation. So we're really trying to build an internationally active movement where everyone has access to information. That community is also moderated by eurordis staff, as well as people like Michael from Pseudomyxoma Survivor. And we're trying to help gain insight into international issues faced by people living with PMP on the community and hopefully through this webinar today. So the agenda for today will next be speaking Michael Healy from Ireland. Following him, Dr. Wim Ceelen from Belgium. We'll talk about diagnosis, staging, surgery, and post-operative quality of life. Then Dr. Faheez Mohamed from Basingstoke will talk about pathology, surveillance, and managing recurrence of PMP. And then we'll end with questions and a bit of a wrap-up. So next, I'll throw it over to Michael to welcome everyone.
Thank you, Rob. Hi, everybody. Thank you for joining our session today. As Rob said, my name is Michael Healy. I'm based in Ireland. I'm a PMP survivor, having had successful surgery at Basingstoke in January of 2012 with the very wonderful Irishman, Mr. Brendan Moran, and the team over there, which of course also included Mr. Mohamed. I'm happy to report that I'm currently doing well. I do some volunteer work with the charity Pseudomyxoma Survivor, which, as many of you know, is a UK-based non-profit organisation registered in 2011 and is run by patients and caregivers. We have volunteers all over the world. We have a thriving support community providing emotional support to anyone whose life has been touched by PMP. The charity is a member of eurordis, the European Rare Diseases Organisation, and we are a founding host organisation of the Pseudomyxoma support community on Rare Connect. Our website is pseudomyxomasurvivor.org. And in this session, we are joined by two of the charity's medical advisors, Mr. Mohamed, based in Basingstoke, UK, and Professor Ceelen, based in Ghent in Belgium. It is hoped that this will be the first of a series of Q&A sessions, and I would particularly like to thank Angela Brooke and Rob for doing all the background work in coordinating this particular session. Before I hand over to Professor Ceelen to give us his insight, I would like to take this opportunity to offer our gratitude to both Mr. Mohamed and Professor Ceelen, firstly for providing ongoing medical advice to the charity. It is clearly of great benefit to any organisation to get the opinion of subject matter experts on topics as they come up. Secondly, for their great skill and dedication as surgeons, as they give so many of us a second chance at life by carrying out this very complex surgery, which as patients we know is very challenging not only to the patient but also to the surgical teams involved. And finally, for taking their time out of their busy schedules today to give us some further medical insight into topical subjects among the patient community. So, Professor Ceelen will discuss diagnosis, staging, surgery, and post-op quality of life. So I hand over to Professor Ceelen. Thank you.
Sometimes called jelly belly, and this is in fact named after typical accumulation of a mucin-rich ascites that is forming progressively in the abdomen, and you can see an example of this here. Now, the name Pseudomyxoma Peritonei was coined in the 19th century by a German surgeon called Mr. Wirth, and in fact several other names have been coined for this disease over the years, but the currently accepted term is Pseudomyxoma Peritonei. Now, it's important to realize that this is a clinical term that just describes the presence of mucinous ascites into the abdomen and does not reflect the underlying cause or the aggressiveness of the underlying disease. Now, the origin of pseudomyxoma was originally thought to be lying into the ovary, but over the past few decades, there is now an increasing body of evidence that points to the appendix in nearly all cases. So it's a mucinous or mucin-producing tumor of the appendix, which eventually ruptures and causes spread of mucin into the entire abdomen. In rare cases, the cause can lie, in fact, in the ovary or in a number of other organs that you see there, such as the stomach, the colon, the large bowel, even the lung and the breast, etc. But those are very rare. In fact, in almost all cases, pseudomyxoma originates in a mucin-producing tumor of the appendix. You can see an example of such a tumor here. This is the ileum, the small bowel. The colon is somewhere over there. This is the appendix. It's in fact quite a short appendix. And here, at the tip of the appendix, you can see that there is a mucin-producing tumor which has ruptured and which has caused the clinical picture of pseudomyxoma with the presence of a mucinous ascites throughout the abdomen. Now, I will not go into detail about the histological classification because Faheez will discuss that. But in fact, there are two main variants, a low-grade, less aggressive form of the disease and a high-grade, more aggressive variation, which is even more aggressive if there's the presence of signaturing cells. Now, what are the usual symptoms of patients with, who present with a pseudomyxoma? Usually this starts with an increasing abdominal circumference, and patients often assume that they are just getting a little overweight. But then in the course of time, they start having problems with bowel function, with bloating, with nausea, with vomiting, and in advanced cases, they actually start to lose weight. And specifically in male patients, the disease can present by a hernia because of the increased abdominal pressure, and typically patients are referred by a general surgeon or by a GP because of the presence of an umbilical or an inguinal hernia, and when this is then operatively treated, the treating surgeon notices the presence of mucin in the hernia sac, and this then points to the diagnosis. You may know that the disease is a little more common in female patients, and of course in women it can present as an ovarian mass, and this is in fact a metastatic location into the ovary. The ovary is a very good breeding ground, so to say, for any type of peritoneal metastasis, including the mucinous appendix tumors. And it can be an unusual finding. So what about the technical exams that are usually performed after the diagnosis is made or suspected? Well, the first thing that is usually done is a CT scan of the chest and the abdomen, and typical signs that are visible on a CT scan are the presence of ascites, of a mucinous ascites, of a thickening of the omentum. The omentum is a kind of fat tissue that is adherent to the stomach and to the colon, to the large bowel, and which has a role in immune defense of the peritoneal cavity against infection. And there's usually a massive involvement or thickening of this omentum, and that can be noticed on a CT scan. The peritoneum is thickened and clearly affected by the disease in some typical locations, specifically the diaphragm. And this is caused by the fact that every time you inspire, there is negative pressure below the surface of the diaphragm, and so the cancer cells and the mucin are drawn upwards. And by the same mechanism, by gravity, there is usually a thickened peritoneum and the presence of implants in the pelvis, so the space between the rectum and the bladder, or the rectum and the female patients. The main disadvantage of CT scan, apart from the fact that you need X-rays and repeated CT scans can result in a dangerously high dose of X-rays, is the fact that small implants smaller than 5 millimeters are usually not visible on a CT scan, and that's why, in fact, we are looking for better ways to image and to stage peritoneal disease, including the pseudomyxoma patients. And one of the techniques that seem to be promising are whole body MRI with special diffusion weighted sequences. The disadvantage of that exam is that it is quite time consuming and can be therefore quite a burden for patients. PET-CT with nuclear tracers such as 18-fluorine may have a role in patients with high-grade disease, but in low-grade disease with very slowly evolving nodules, usually PET-CT will not show, because this technique is usually restricted for fast dividing cells and adenocarcinomas. What is important to assess on the CT scan is, of course, the extent of the disease, and there are several staging systems that have been described in the literature, such as the PCI, the Peritoneal Cancer Index, which describes the number and the size of the nodules that are spread throughout the abdomen. It's important to note whether or not the small bowel has been involved, because affection of the small bowel is important in the sense that if this is massive, then surgery is in fact not possible. You can remove a part of the small bowel, but obviously not the entire small bowel, because this is incompatible with normal life, in fact. The porta hepatis, so this is the place where the large vessels and the big bile ducts enter the liver, is also a place of major importance, because if that is involved or infiltrated by cancer, then surgery is really, really difficult or impossible. So the CT scan, other imaging, tumor markers are measured in the serum, specifically the CEA, carcinoembryonic antigen, which is also used in a number of other cancer types, mainly GI cancer types, such as colon cancer, CA19.9 and CA125. I will not go into detail, but you should realize that patients who have an elevated tumor marker at diagnosis have a higher risk of recurrent disease and a more aggressive disease usually. And probably Dr. Mohamed will go into detail on that when talking about recurrent disease. Usually patients receive a colonoscopy for two reasons. First of all, the diagnosis can be confirmed when mucus is seen from the inside. And so through the colonoscopy you can sometimes see mucus extruding from the lumen of the appendix from the inside. That's one. And two, it's important to exclude synchronous colon lesions and polyps, because sometimes patients with an appendiceal tumor harbor colon polyps or even colon cancer at another location, and it's of course important to know that beforehand and to treat that at the same time during operation. In some patients a diagnostic laparoscopy is performed, but this is usually reserved to patients in whom the resectability of the disease is in doubt, or when there is real doubt about the diagnosis. But I must say that the CT image and the whole context of symptoms and signs is really quite typical, and therefore a diagnostic laparoscopy is usually not performed as a routine, at least in our center. This is a typical CT image. You can see here what is called scalloping of the liver. So there are indentations on the normal liver surface. The liver is the large organ here, and you see that this dark zone is in fact mucinous ascites, which compresses and impresses on the surface of the liver. This is really an advanced case. In less advanced cases, there is only production of ascites, as you can see this dark gray zone around the liver and the organs. This is a typical image of Pseudomyxoma Peritonei. In this image, you can clearly see the tumor of the appendix, which was at the origin, in fact, of the whole process. So how is pseudomyxoma treated? There are several treatment options. You can do repeat surgery just to alleviate symptoms. This is still performed as a routine in some centers in the world. But most patients will receive what is called a complete cytoreductive surgery or a debulking surgery, most often in conjunction with hyperthermic intraperitoneal chemoperfusion. So the HIPEC technique, which I will discuss in a little detail in just a moment. In some centers, the administration of heated chemotherapy is followed by what is called HIPEC or early postoperative intraperitoneal chemotherapy, and this means that immediately after the operation, patients receive an indwelling catheter, and during the first 4 to 5 days after the operation, chemotherapy is administered into the abdominal cavity through this catheter. Systemic chemotherapy, so the normal intravenous chemotherapy, certainly has a role in high-grade disease, patients with signet ring cell histology, and this can be administered either before the operation, after the operation, both, and if you give it both before and after the operation, it's called perioperative chemotherapy. But at this point, there are no studies which have definitely proven the role of systemic chemotherapy in this setting. However, it makes sense to draw a parallel with metastatic colorectal cancer, where, of course, chemotherapy is active, and more centers are really offering systemic chemotherapy in patients with high-grade mucinous appendix tumors in order to improve the survival and recurrence. So the operation itself is quite extensive, quite heavy, in fact, to go, and it's a combination of organ resections when required, and most commonly, of course, the appendix, not only the appendix itself, but the region where the appendix is attached to the cecal segment of the colon is removed. Parts of the colon are usually removed, and the rectum is also often removed because, as I noted earlier, there is often disease between the rectum and either the uterus or the bladder in many of these patients, and of course it's always better to remove all the disease en bloc in one piece, and this entails often removal of the upper part of the rectum. Other organs are part of the organs that are sometimes removed partly, not completely, of course, but partly are the tail of the pancreas, segments of the liver, the ureter or the bladder, etc., etc. So organ resection is one part of the operation. The second part of the operation is what is called peritonectomy, and it's in fact a procedure where the peritoneal lining is stripped, is removed from the underlying muscle. It's of course not indicated to remove normal peritoneum, but only the peritoneum which is involved by cancer nodules, by tumor implants. It's removed by this process of peritonectomy. It's a procedure which is time consuming. It takes on average 8 hours, so it's very important that aspects like positioning of the patients, prevention of fluid overload, prevention of deep thrombosis, prevention of hypothermia, etc., is looked at in detail, and anesthesiologists have a major role in making this surgery effective but also safe. This is a drawing that illustrates this concept of peritonectomy. You see here that the peritoneum, or the epithelial lining of the peritoneal cavity, is grasped by a number of clamps, and then you can remove the peritoneum from the underlying muscle by a process which is called peritonectomy. And this can be performed in all quadrants of the abdomen. It's much more easy to remove the peritoneum from the abdominal wall. It's more difficult to remove it from the mesentery of the bowel, for instance, or from the surface of the small bowel, where it's usually requires removal of a part of the small bowel rather than try to strip the peritoneum from the surface of the small bowel, which risks, of course, to cause a perforation. So what about a HIPEC? So as you know, this stands for hyperthermic intraperitoneal chemoperfusion. And what we do is, after the completion of the operation, when we succeed in removing the disease completely or nearly completely, there is a perfusion circuit which is installed, and then heated chemotherapy is given into the peritoneal cavity. So it's done during the same anesthesia, during the same procedure. There is no standard way to do it. There is a large variety of methods that are used worldwide. The duration of the chemotherapy perfusion takes anywhere between half an hour and 2 hours. The chemotherapy that is used is usually for appendiceal tumors. It's either mitomycin C or oxaliplatin. Oxaliplatin is also the standard of care for the intravenous treatment of colon cancer, and that's why we prefer it. But there's probably no difference in efficacy or safety between both drugs. Each have their own specific side effects. The platinum products, specifically oxaliplatin, are known to cause slight nerve damage and can cause neuropathic pain and kind of tingling sensation into the toes and fingers specifically. The temperature that is used is anywhere between 38 and 42 degrees. It depends a little bit on the extent of the surgery and the anticipated risk. For instance, if you have to construct several small bowel anastomosis, we do not tend to apply a very high temperature because invariably you will end up with edema of the small bowel, which can compromise the healing of the sutures and the anastomosis that you have made. During the installation of the chemotherapy, the abdomen can be either left open, and this is called the open technique or the Colosseum technique, or it can be closed, or it can be done with a kind of in-between solution where there is a kind of gel port that allows access of the peritoneal cavity by the hand of the surgeon. So as you can see, there's a variety of methods, and probably all methods are equivalent in terms of efficacy. This is how it's done in our center. So after the operation, the skin is attached to this kind of frame, and then afterwards the whole setup is covered by a plastic sheet, which is not shown here on this illustration. We place a number of temperature probes into the abdomen, the white lines that you can see here, these temperature probes, and then there are a number of inflow and outflow catheters. The white arrows here point to the inflow catheters, and the black arrows point to the outflow catheters, so 2 in, 3 out. And then the perfusion is performed using this apparatus, which is in fact quite simple, and it consists of a pump, a roller pump, which drives the fluid around, and then a heating element which allows to heat the perfusate at the temperature of between 38 to 42 degrees. So what about systemic chemotherapy? As I have told before, it can be considered, and it should be considered, in patients with a high risk of recurrence, so patients with an elevated CEA, patients with a high-grade histology, or patients with signet ring cell type histology. Those are very, very similar to the classical aggressive colon cancer adenocarcinomas, and probably these patients benefit from chemotherapy at a certain point in time. The agents that are used are in fact the same as those that are used in colorectal cancer in most centers, including ours. So it's a combination of platinum compounds or irinotecan in combination with 5-FU, and these schedules are then called CAPOX or FOLFOX, etc., etc. And in many patients, this is combined with what is called biologicals or targeted therapy. These products are available. It depends a little bit on the local healthcare setting, whether or not they are reimbursed. I think in the UK, maybe the restrictions for the use of biologicals is maybe a little bit more severe than in other countries, such as the US, where there's a very liberal use of these products. So it depends a little bit on the healthcare setting. Typical products are Avastin, which is a product that blocks the formation of new blood vessels by the tumor, and also other biologicals such as this one may be used in patients with high risk or advanced or certainly metastatic appendiceal tumors. Chemotherapy is, when it is given intravenously, it's not given once, like in the HIPEC setting, but it's given in repeated courses. Usually it's 12 courses every 2 weeks, so this takes between 3 and 6 months. Chemotherapy for appendiceal cancer and for colon cancer is usually very well tolerated, and the quality of life in these patients is usually quite good. So to finish, a few words about quality of life after surgery and HIPEC, which is of major importance. I must say that it's an aspect that it's a little bit neglected by the surgical community. Not these studies go into quality of life. There are only a handful of publications which have described and formally evaluated quality of life in these patients. It is important because it's extensive surgery, and a number of operative procedures will significantly affect quality of life. And, the presence of postoperative complications, for instance, if patients develop a bowel leak or an anastomotic leak, and we know that when you give intraperitoneal chemotherapy, the risk of anastomotic leakage is higher, then quality of life will, of course, be affected. The same is true for the situation where you have to do an extensive small bowel resection and you end up with what is called a short bowel syndrome, or if you have a very proximal ileostomy, so a bag on the small bowel but very close to the stomach, then patients will need parenteral nutrition, so nutrition via an intravenous catheter at home, and this of course is something that will affect the patient's quality of life significantly. In many patients, a part of the rectum has to be removed, and this results in a varying severity of what is called the low anterior resection syndrome, which means that patients have difficulty with having a normal continence, so they cannot defer going to the toilet for a very long time, and this of course can affect the quality of life. When parts of the stomach, and especially if the complete stomach is removed, then quality of life is also significantly worse, especially the first months after surgery. And patients struggle with weight loss and with disturbing symptoms in patients, which are usually well manageable by, for instance, prescribing what is called anti-acid therapy or proton pump inhibitors or similar drugs that reduce the production of gastric acid. So this is an example of one of the few studies that have looked at quality of life after debulking surgery for pseudomyxoma. And you can see here in this axis the course of time in months, and this in this y-axis you see the quality of life, which is in arbitrary numbers, but you see here the moment before the operation. This is 1 month after the operation, and you see that there is a significant decline because it goes down, quality of life goes down. But then in the course of time, you see that this recovers, and most patients have a better quality of life 1 year after the operation, and this you can of course understand because if you have an untreated pseudomyxoma, this of course affects your quality of life. So my last slide concludes more or less this aspect of quality of life. It has not always received due attention in clinical studies. It's important that this is addressed not only by the treating surgeons or consultants, but by a multidisciplinary team, which is of course in place in all of the centers that treat these patients, so stoma nurse, dietitian, oncology nurse, psychologist, etc., etc. And of course, patient support organizations like yours are very important in order to allow counseling and exchange of advice and experiences. And this is probably of major importance for patients' quality of life, not only physical, but also their emotional well-being after having undergone this type of very extensive and also expensive surgery. So on that note, I would like to conclude. I thank you for your kind attention, and I am available for answering any questions you may have. Thank you.
Thanks very much.
Wim, for that excellent presentation. I'm just going to follow on and cover a few things about the pathology of pseudomyxoma, follow-up, and how we manage recurrence, which can be a challenge. Nice to see Michael looking so well there. We'll start with we're just talking a bit about the pathology. So it's something that's been poorly understood for many years. Paul Sugarbaker, probably about 20 years ago, sat down with a pathologist and they tried to describe what these tumours look like, and came up with a classification which is essentially what a lot of people have been using for many years now. Recently, people have been trying to standardise how we describe these tumours, and certainly a few years ago in Basingstoke, a number of those pathologists who work with pseudomyxoma met, and we tried to come up with an international classification that everybody would agree on. And broadly speaking, I think we've done that in terms of dividing these tumours into low-grade, high-grade, under the pseudomyxoma umbrella, and then out with that, there are tumours that behave more like bowel cancer, which would be classed as adenocarcinoma, but also tumours that have unusual features such as signet ring cells or goblet cell adenocarcinomas, which are again very rare subgroups. The majority of appendix cancer is low-grade pseudomyxoma, about 75%. But a small proportion is high-grade or adenocarcinoma. And the reason why that's important is because those tumours are more likely to end up with lymph node metastases. Now, when we look at pathology, when people write to us, what we want to know is if they've had an appendicectomy, for instance, was the tumour perforated? And if it was, were there epithelial cells out in them? Because if there was, the risk of developing pseudomyxoma is much greater. So a number of patients come to us having had an appendicectomy. They have an incidental finding of a tumour, and people want to know, well, what should I do now? And in that case, we want them to send the slides to us, and the reason for that is so we can estimate what the risk is to those patients in the future. So if you have a low-grade mucinous tumour, like most of them are, your risk of having the lymph nodes involved, draining the appendix, is quite small. But if it's a high-grade tumour, then it's about 20%. And if it's an adenocarcinoma, like a bowel cancer, then it's much higher, probably about 50%. And so what we'd recommend differs based on what the tumour looks like under the microscope. There's also an indication that the high-grade tumours, or the adenocarcinomas, are more likely to respond to chemotherapy. As Wim mentioned, the evidence to support that isn't that strong. But we're interested in the pathology because it has an impact on how we might treat the patients. So looking at our experience from over 1,000 appendix tumours over the last 20 years, the majority you can see in that red circle are low-grade tumours. So it's about 80%, and about 16% were high-grade, so that still comes under the umbrella of pseudomyxoma, and then just under 4% were adenocarcinoma. And that's not really pseudomyxoma, that's a disease that's far more active, and that we have to be very wary of, because we need to treat it slightly different to pseudomyxoma. And really, just to bring out the point that not all appendix tumours are pseudomyxoma. So people assume that once they've seen an appendix tumour that it's pseudomyxoma, but there's a whole variety or a spectrum of disease. From one end, a very slow-growing tumour which is unlikely to spread outside of the abdomen or to the lymph nodes, to the other end, a tumour that behaves very much like bowel cancer, although on the whole these tumours tend to do better than bowel cancers. So we're moving towards understanding these tumours a little bit better and standardising the pathology. We're still not quite there yet, and one of the challenges is that they're so rare that many pathologists who'd see these tumours around the country or around the world may never have seen one of these tumours before. So we often ask referring centres to send us the slides so we can have a look at them again and be sure that we're dealing with what we think we're dealing with. So why is the pathology? Well, from our own experience, able to remove all the disease, we know that's the most important determinant of a good outcome. People living for a long time and potentially being cured. But we know that if the pathology, it shows that this is an adenocarcinoma, then despite being able to remove all the disease, those patients don't always do as well. And we would certainly consider them having some systemic chemotherapy afterwards if they had an adenocarcinoma, just to reduce the risk of them running into trouble in the future. But you can see there that the survival for those patients with a low-grade tumour, I mean, that goes out to way past 5 years, almost 10 years. You can see that the majority of people are still alive now. DFS means disease-free survival. So that means they've not had a recurrence, and they've basically, and it's the number of people that are alive at that time. So this is based on our figures from 1,000 patients, and which is why it's important for us that we know what the pathology is. Another thing that we're beginning to understand is that pathology isn't the whole story, and we've been checking tumour markers, that CEA, CA125, and CA199, and we check those before surgery and also after surgery. They give us an indication if the tumour's going to come back. They can give us a warning, an early warning sign. But this paper here, we looked at patients who had a complete tumour removal, so a complete cytoreduction, and we looked at what their tumour markers were like before they had their operation. And then we were able to look at how long they survived afterwards, based on whether their tumour markers were all normal, or whether one was elevated, whether two were elevated, three were elevated. So you can see here, if all the tumour markers were normal for their surgery, then the survival there is actually much better than if all three of their tumour markers were elevated. And this is actually independent of their pathology. So most of these tumours, you remember, were actually low-grade tumours. So it just paints the point, or brings out the point, that the pathology isn't everything. And we probably don't understand the pathology well enough, or we're not describing it in enough detail to be able to predict how exactly patients are going to do. But you can see from these tumour markers that they can give us a clue. So there's a difference here between having all three tumour markers elevated and having none elevated. And it may be that in the future we use that as an indicator for patients who, after their complete tumour removal, may benefit from some chemotherapy as an extra layer of protection against the trouble. And this is really looking at that same data in a slightly different way. Now this hazard plot essentially just shows us what the chance of you having disease recurrence is if your tumour markers were up. And you can see here, this red curve here is for patients who had all three tumour markers elevated before their surgery. And a good number of them had their disease come back again, and that came back in the majority of people within 2 years after their surgery. Now that doesn't apply to everybody, but we need to keep a close eye on those people. If you didn't have your tumour markers up, then the chances of you getting disease back again is much lower. And this is just a paper we published looking at what happens to tumour markers within a week of having your tumour taken out. And interestingly, those tumour markers drop right away. So they're useful to monitor after surgery so that you can tell if people may be getting disease back again. So, what is the optimal follow-up? How frequently should we scan people? How frequently should we check their tumour markers? When we looked at our 1,000 patients who've had appendiceal tumours over the last 20 years, we plotted out how many patients were alive without any disease recurrence. And you can see here that the majority of people, if they're going to get their tumour back again, it happens within the first 5 years of their surgery. So you can see here that essentially this is the proportion of patients who are alive without any recurrence is down to about 5 years. The majority of people who are going to get their tumour back have had it back, and then after that there's much less. You're talking about from 69% to 63%. So really the intensive follow-up should probably be in this first 5 years, and once you make it to that, we can space that follow-up out. And so we've recently changed our follow-up from being annually for 10 years to being annually for 5 years after surgery. And then once you get to 5 years, we'll scan you again probably at 7 years and 10 years, and then 15 and 20, because the risk of you running into trouble after 5 years is much lower. Now, we do that, and the reason we follow people up is so that we can pick up disease recurrence if it arises. But then if you do that, what do you do? So we pick up that recurrence at the moment with imaging, and that tends to be CT scan, although as Wim says, MRI can be very useful in this setting, and certainly for colorectal cancer, MRI is being used quite widely enough to know which ones will respond, or you can consider further surgery with HIPEC to try and deal with that recurrence. We know that there are certain areas where the disease recurs that makes it less likely for us to be able to tackle that surgically. If you have disease on the small bowel surfaces, that's always a challenge. Disease in the pelvis or disease spread out throughout the abdomen is less easy to tackle. And also, if disease hasn't responded to chemotherapy, well, we don't know why people develop recurrence now. We don't know whether it's the biology of the disease itself, or whether maybe they didn't respond to the chemotherapy, the HIPEC that we gave them. The issue with that is a single shot of HIPEC if people if we're able to remove that disease, then those people still do better than if we can't remove that disease. So in selected patients, it's certainly worth considering. And that's the figure there. So out of about 750 patients, 500 of those had a complete tumour removal, and 130 of those had recurrent disease, you can see there. We operated, and this paper is a couple of years old now, but we'd operated on 35 patients there, so it's certainly not the majority. And out of that, we were able to remove all the tumour again in 20, but we couldn't remove all the tumour in 15, and we know that a complete tumour removal is going to give patients the most. We probably, when we looked at our data, if you were at the patients who were above the median age, which was 56 of our patients, then they were more likely to have recurrent disease if they had elevated tumour markers. Interestingly, I think the blood transfusion is really a reflection of how extensive the disease is, rather than the blood itself. If we took part of the stomach away as part of as the initial operation, again, that's an indication of how extensive the disease was. So we've done that in about 80 patients out of the 1,000 waited on. So it's a small number, but it's a reflection of how extensive the disease was. And if they had a high-grade tumour or an adenocarcinoma, they're also more likely to get disease back again. Now, can we prevent recurrence? And that's the big question now. We'll keep giving chemotherapy to those patients. Is that going to reduce them, reduce the risk of them getting disease recurrence? We don't know is the answer. And it would be difficult to do a trial to prove that. I think our feeling is certainly now if patients have got high tumour markers, even if they've got a low-grade tumour, which suggests they had a discussion with an oncologist. But again, the evidence to support having systemic chemotherapy it isn't that strong. Choosing the drug now, Wim mentioned there probably isn't much difference between oxaliplatin and mitomycin C, and you know, does everyone respond to the chemotherapy, the HIPEC, in the same way? Again, we don't know, and there are a few people who think that that not everybody responds to mitomycin C, and that some people may, if they do get recurrence, it may be as a result of that, but there isn't really any strong evidence to suggest that, and we don't know really, at the moment, we don't know who's going to respond to what drug. And if we think someone's more likely to recur, should we be keeping a closer eye on them? Should we be scanning them more frequently? I mean, that's something we probably need to look into in a bit more detail. Perhaps not so much in pseudomyxoma, but in colorectal cancer now, people are talking about planning a second look. So this is in people who have got no symptoms. There's no sign of any disease on their CT scan, but you're having a look because you've got a suspicion that they might have disease or they were at high risk of developing recurrent disease. Now that's a bit controversial thing because that's not without risk, and you don't want to put people, you don't want to cause people trouble when they don't necessarily need it. If people do get recurrent disease, then who are those people who are going to benefit from having further surgery? Certainly in our experience, if you're having symptoms because of your recurrence, then there's a good reason to have a look. If you've had disease recurrence and there's been a long interval between you having your initial surgery, between you having your initial surgery and your recurrent disease, then there's more of a reason to have consider surgery rather than other treatment like chemotherapy. If you had very extensive disease and we did a complete cytoreduction, then the chances of us being able to achieve another complete tumour removal if your disease has recurred is less, because if we've stripped all the surfaces, then it's not easy to get into those areas again without causing more trouble like complications. So we tend to reserve a second look for recurrent disease to those patients who've only really got very localized disease recurrence. And again, low-grade tumours, patients with low-grade tumours are more likely to benefit than those with high-grade tumours because of the disease biology. And a lot of people ask, well, why are we watching and waiting? You know, is that sensible? And I think one of the reasons for being able to do that is it's rare for these tumours to spread to the lungs, to the inside the liver, or outside of the abdomen, and we can keep an eye on things without missing an opportunity. Things tend to progress fairly slowly. We know that if you've got symptoms, if we do operate, there's a good chance we're going to make you feel better. If you haven't got any symptoms, then an operation isn't going to make you feel any better, and it might actually make you worse and give you trouble that you didn't have before. And you know, this surgery is not without risk, as those of you who've had the operation will know. So that really is a whistle-stop tour through what's quite a complex and challenging topic, but it just gives you an idea of our current thinking in terms of how we follow patients up. and what we do when we find disease. Thank you.
Lots of us are different from each other, and I suppose it causes lots of confusion in the community. So I would like to congratulate you both on your fantastic presentations today. So clear, spoken, I suppose, with the patient in mind, so that we can understand quite clearly in English what the message you're trying to give across to us. And I think a simple thing like we've all seen these diagrams and these graphs, but of course we all question. One person reads them one way and another person reads them another way. So to have, I suppose, two people with the expertise that you have to explain clearly what those graphs mean is absolutely fantastic. So thank you from the bottom of our hearts as patients. I suppose it helps us educate our community in giving accurate and concise and information that can be easily understood back to the patient. So thank you, both of you guys. Thank you.
Thank you.
It's impossible to enter the abdomen again because of severe adhesions, etc. But in fact, in my experience, that's not really the case. In fact, I have done a series of patients who have undergone repeat cytoreductive surgery and HIPEC, both in pseudomyxoma and in other cancer types such as ovarian cancer and colon cancer, and usually it's not a problem. Although it is of course true that the more often a patient is operated into the abdomen, the more extensive the adhesions will be, but that's per se never a contraindication for surgery. I also noticed a question regarding the fact whether or not there is a regrowth of the peritoneum and of the omentum. Well, the omentum does not grow back. Once you remove it, it does not grow back. There's only one organ in the body that grows back after you remove a part, and that's the liver. The peritoneum can grow back in certain places. If you remove a circular patch of the peritoneum from the abdominal wall, it will close from the borders, growing inside again. But that's not universally the case. For instance, between the liver and the diaphragm, you will not see regrowth of the peritoneum, because usually after the operation, the liver surface attaches to the diaphragm quite closely, quite firmly, and at that location you don't see regrowth of the peritoneum. But that being said, whether or not the peritoneum regrows does probably not have any physiological meaning, or does not entail any risk for the patient. I don't know if you agree, Faheez? Have any?
Yeah, I agree. Can you hear me? Is your microphone on? Let me just check. Can you hear me? Yeah. Can you hear me now? Yeah, good. So I agree with everything that Wim has said, and often I think the chemotherapy, the HIPEC, can reduce adhesion formation, and it can be quite pleasantly surprising if you're reoperating on patients that actually there are very few adhesions. So I mean, you need to be careful, but it's often not as bad as you might think. But again, those areas where you strip, like the liver, they tend to fuse together with the diaphragm, and so it's very difficult to get into those spaces again. So we just need to be wary of that. But if it's often with other types of surgery, the adhesions can be very challenging to manage. But that's not always the case with Cytoreductive, especially if you've used the HIPEC. There's a question here on tumour markers. I'll just what's defined as a high score from our point of view, from those papers that we that I presented. Anything above the normal range is classed as I mean, it's high, but there are different levels of high. If someone's got a C, say for instance, someone has a CA 125 of 100, then that's different to having a CA125 of 5,000. So if people have got tumour markers in the thousands, then that tends to be an indication that they've got quite an active tumour, or certainly a high-grade tumour. And we'd be worried about that. Not that we wouldn't take them on for surgery, but we just keep that in mind in terms of how we followed them up and the treatment they had after that.
There's a question there about spread to the lungs. It is true that if during the operation you open the diaphragm, there is a risk that the disease will spread to the pleural lining. So the pleura is in fact a similar structure to the peritoneum, and you can have carcinomatosis which covers the pleura, so the lining of the chest wall and the lungs. And if that happens, in principle, patients may be candidates for chest surgery, where in the same way as in the abdomen, all the nodules are surgically removed, and then chemotherapy is given into the pleural cavity. I've done that in a few patients, and the results seem to be very similar to that of the peritoneal treatment, or treatment of the peritoneal carcinomatosis. But it's true that it can spread directly from the abdominal cavity to the pleural cavity, either spontaneously when the disease infiltrates the diaphragm and it perforates the diaphragm, or by opening the diaphragm during the operation. In theory, there is a risk that disease will spread into the pleural cavity. So it's not a pulmonary metastasis, but it's really spread on the pleural lining of the chest wall, in fact.
There's a question here on patients being told they have cancer, but a few being told they do not have cancer. I think traditionally people regarded pseudomyxoma as a borderline malignancy, which is not a very helpful term. And we've certainly moved away from that. And if people, mainly insurance companies, will ask us, does your patient have cancer or not? Then we'll say yes, they have cancer, because the tumour is dividing, or the cells are dividing out with the normal control of the body, and they can infiltrate or they can invade other organs, and so it would fit the traditional definition of a cancer. So I think if you have Pseudomyxoma Peritonei, then it's a cancer. It's different to other cancers, and it's probably got a much better outlook if you can get rid of it all than many cancers, but it's still a cancer nonetheless.
There's a question there about chemotherapy, and the specific question is why is the type of chemotherapy given on a trial and error basis, and why is there not enough data on chemo effectiveness? Well, first of all, this is caused by the fact that it's a rare disease, and if you want to test different types of chemotherapy, you need hundreds of patients in order to find out whether or not there is an effect on the risk of recurrence or the risk of dying from the disease. So that's one aspect. The second aspect is that there are at this point no good biomarkers. So a biomarker is, for instance, a substance that you can measure in the blood and that will predict the response or the success of chemotherapy. For this specific disease, there are no biomarkers available. For other diseases and other drug types, there are biomarkers, very, very few, I must say. But unfortunately, for products like oxaliplatin or irinotecan, there are no predictive biomarkers yet. This is a very active field of research, of clinical research, but unfortunately, at this point in time, there is no way to predict the activity of oxaliplatin, whether it is used in bowel cancer or appendiceal cancer. So that's one of the reasons why it's often indeed used as on a trial and error basis. There's another question here about adhesion prevention. I don't know what your experience is, Faheez. There are centers that use anti-adhesive barriers. I'm not a big fan, and I'm not convinced of their effectiveness. Do you use any particular measures to prevent it?
No, we don't. And I think there's always a worry that we might delay healing of any joints in the bowel by using that. And certainly in other types of surgery, there are some reports of that, what we call anastomotic leak, or where we've made joints in the bowel, because those barriers that you can use not only stop adhesions forming, but they can also delay healing, healthy healing. So we've tended not to use those. We've tried to stay away from that.
I agree.
There's a question here about not having any, about the symptoms of recurrence, and often one of the challenges of recurrent disease is that you don't get any symptoms, because you get disease that's just picked up on a scan. You won't have any symptoms, and part of the reason for doing the scan is to identify those areas so we can watch them, and then decide over time if we need to do anything about them, or if we can do anything about them. But it creates a lot of anxiety, understandably, for patients, because once you know that it's come back, you're just waiting for it to cause trouble. But it doesn't necessarily always do that. And so we certainly don't want to put people through another operation unnecessarily, which is why often we just say, well, look, let's watch and wait. But it is a real challenge. And on the whole, when we do operate, it's because things are either progressing more quickly than we'd like, or people start to get symptoms. Or it's because people have got very localized disease and we're confident we can remove it without causing too much trouble.
Pseudomyxoma now, immunotherapy is regarded as a very promising treatment. It really was first used in skin cancer and melanoma, but over the last few years there are really success stories to tell now with immunotherapy, and it's probably going to be used in bowel cancer as well in the coming years, specifically in a type of colon cancer that is associated with what is called microsatellite instability, because these patients have more mutations that elicit a response from the immune system. Now, whether or not it will ever be prescribed to patients with appendiceal tumors will depend on the clinical trials that will be performed. And unfortunately, patients with appendiceal cancer are often excluded from participating in trials that look at the value of immunotherapy in colon cancer. But that does not prevent or will probably not be an obstacle to the fact that sooner or later immunotherapy will have a role in combination or as an alternative to the classical chemotherapy in patients with high-grade disease, whether or not it's as an adjuvant treatment, so after the operation, or in patients with irresectable or metastatic disease. So probably there will be a role for immunotherapy, but it's probably not in the near future, but yeah, maybe in 5 or 10 years. I don't know what your opinion on that is, Faheez.
We're probably way off. It's quite an exciting area, but I'm not sure whether we'll be able to use immunotherapy in the near future. But in diseases like peritoneal mesothelioma, I'm sure you know, Wim, that's the big talking point is immunotherapy. And these so-called checkpoint inhibitors, which are being used in lung mesothelioma, and they may have a role in peritoneal mesothelioma, maybe sooner than pseudomyxoma.
Great. Maybe we can have one final question here from Sharon, who's wondering, for low-grade PMP with debulking surgery initial for ovarian cyst, What's an acceptable delay until CRS? How many months?
Yeah, so we get quite a few patients who are sent to us from gynecologists who've had surgery for what was thought to be an ovarian tumour, an ovarian cancer. It comes back and it's an appendix cancer or pseudomyxoma. And in that situation, in some of those patients, all the disease has been cleared. In others, there's some disease left behind. If it's truly low grade, then we like to wait for people to be able to have recovered from their initial surgery, certainly at least 6 months. Before we consider any further surgery, and sometimes we can just keep an eye on things.